So thank you for having me. I'm sorry I couldn't be there, but I'd like to talk with you all. I know that you're getting a lot of different perspectives on different leukodystrophies and hearing from rehab physicians and neurologists and other folks. So I'd like to contribute from my perspective as a geneticist and talk with you about what Cerebrotendinous Xanthomatosis, or CTX, looks like to me as a geneticist, and particularly through the lens of what are the implications of considering newborn screening for this disease and thinking through the follow-up that will result from newborn screening. So I want to start by introducing a fair amount of vocabulary here. These will be the kind of dictionary of terms that will come up in this presentation and help you to follow along with what I'm talking about here. So the disease CTX is caused by a deficiency of an enzyme called CYP27A1, which is involved in bile acid synthesis. CYP27A1, the gene is encoded, the enzyme is encoded by a gene of the same name. And so patients with CTX all have biallelic or mutations in both copies of the gene CYP27A1. And as a result, they have decreased sterol 27 hydroxylase enzyme activity. The term allele is referring to a particular type or a copy of that gene that carries a particular mutation. There are different types of alleles. So you can have something called a hypomorphic allele. So a hypomorphic allele means that there's a mutation in the gene that partially but not completely diminishes the enzyme of the sterol 27 hydroxylase enzyme. And that's just a property of biologic systems, that biologic systems aren't binary. There's always a spectrum. And so some of the ways that this gene is altered are going to result in partial enzyme activity. And that may have implications for the clinical manifestations that result in the most appropriate type of follow-up and management for those patients. I'm going to move into, so another term is genotype. So genotype is the combination of your two alleles. So your genotype is allele 1 plus allele 2 equals your genotype, and that particular genotype conveys a certain amount of residual enzyme activity in the sterol 27 hydroxylase enzyme. I'm going to move into some testing, some technical testing terminology that will be relevant for newborn screening. So one term is sensitivity. So the sensitivity of a test is the likelihood that that test will identify a condition in an individual if the condition is truly present. That's different from something called positive predictive value. So the positive predictive value is the likelihood that a positive test result will accurately identify the presence of a condition. And then lastly, to emphasize the goals of newborn screening, that is a public health program intended to screen the entire population for a disease for which the course of the disease can be improved by pre-symptomatic identification and treatment. So CTX is, as I said, it's a disease that is ultimately a genetic disease. Any patient with CTX has a CYP27A1 genotype. That combination of two alleles results in a certain amount of enzyme activity. And if that enzyme activity falls below a certain threshold, then you have the accumulation of toxic metabolites. Those toxic metabolites are the byproducts of incomplete bile acid synthesis. And those toxic byproducts cause the clinical symptoms of the disease. So some of the symptoms of CTX include cataracts and tendon xanthomas. But most importantly, CTX is a progressive neurologic disease. So the symptoms that we are most interested in preventing or preventing the progression of are things like ataxia, spasticity, cognitive decline, and gait difficulty. So one of the complexities of CTX is that these symptoms don't occur all of a sudden, and they don't occur, many of them don't occur in childhood. So understanding exactly how the genotype interacts with the residual enzyme activity, resulting in a certain level of metabolic perturbation, resulting in certain clinical symptoms, is complicated, and it takes decades to figure out exactly how an individual will be impacted by CTX. So just to help you read these graphs here, these are from a great paper that was published in 2018 by Dr. Eichler and his group. So they show that the median age or the age at which 50% of people with CTX will have the symptom of ataxia is about age 40. And there's a broad range there from people who are symptomatic in their teens all the way to people who don't become symptomatic until their 60s. And the same is true with slightly different age of onset curves with cognitive decline and spasticity, as well as gait difficulty. So it introduces this complexity to CTX, which is that there's not only the question of if someone will develop a particular symptom, but also when. So there's multiple variables that this can vary on. So one of the nice things about CTX that we've found in reviewing the literature about this disease is that we expect that genetic testing will have a very high sensitivity for CTX. So we have reviewed 248 publications describing over 800 patients with CTX. There were no patients that had clinical and biochemical evidence of the disease that were not found to have rare and suspected causative variants in CYP27A1 upon genetic testing. There's one publication in the literature that proposed that scenario, that they felt that they had found a non-CYP27A1 cause of CTX. They later retracted that publication or published an update using more modern genetic testing techniques that had better sensitivity and found that that patient indeed did have two suspected pathogenic variants in CYP27A1. So that's a really helpful position to be in, and that's a position that we're not in for every metabolic disease. So for example, ornithine transcarbamylase deficiency is an important metabolic disease for which genetic testing actually has much lower sensitivity. So having established that, that genetic testing has relatively high sensitivity, the next question is, can that genetic testing be helpful in terms of instructing us about what the most appropriate management strategies would be for a particular patient? One of the things that I'll mention from the perspective of newborn screen follow-up is that genetics and biochemistry work well together. So we have, a lot of y'all in this room were probably present for Mike Gelb's presentation yesterday. Dr. Gelb and some other folks who are working in this field, like Dr. DeBarber and Dr. Vaz, they make a really compelling case that biochemical testing for CTX has extremely high quality performance. So there's very high, we think very high sensitivity, very high positive predictive value of the results that we're getting from biochemical testing of blood spots. So the work is ongoing in that area, but the initial data appear very promising in terms of the performance and the characteristics of that biochemical test. So thinking from the perspective of a biochemical geneticist who is getting calls from the newborn screen lab about positive results on newborn screening, I really want to be in a scenario where I have a really good follow-up test where I can take any positive result and be able to relatively quickly adjudicate whether that's a true positive or a false positive. If it's a true positive, what's the expected severity of disease, and what's the most appropriate follow-up for the patient. So for this scenario where we have both high sensitivity biochemical testing and high sensitivity genetic testing, that's a good scenario to be in. So two independent tests that are assaying for the same condition using two completely different technologies is a really good scenario. And it becomes very powerful in terms of being able to accurately identify true diagnoses. So the best example of how this works is something called Pagans Nomogram. So Pagans Nomogram was published in the 1970s. This is a simplification of something called Bayes' theorem. And this is a nomogram that is used to apply Bayesian reasoning or Bayes' theorem to medical information and diagnostic evaluations. So thinking from the perspective of newborn screening, every single disease that you're testing for, you have a low pretest probability. By definition, these are rare diseases and you're testing the entire population. So the likelihood that any one individual has the disease of interest is very, very low. So even if you have a really, really good test, and we think that we do have a really, really good test for CTX, the likelihood ratio, meaning the multiple by which that disease has become more likely upon getting the information that a patient has a positive test result, that can only get so high because of things like sample mix-ups and clerical errors in the lab. And there's no perfect system, even if you have a really, really, really good test. So you always need to have a follow-up. You always need to have a way, a second independent source of data to identify whether a disease is truly present or not. The great thing about Bayesian reasoning and Pagans Nomogram is that you can use these iteratively. So for a patient, a newborn screening patient that started out with a very, very low pretest probability of having the disease, a really, really good test has a high likelihood ratio, but that's still not going to land you in a post-test probability scenario where you can say that a patient definitely has a disease. So this is newborn screening, not newborn definitive diagnostic testing, right? So newborn screening is meant to result in a circumstance where you have a much higher post-test probability than pre-test probability, but your post-test probability is still not going to be 99 or 100%. However, you can follow up that test. So this is just a hypothetical example, but say you've gone from a 1 in 10,000 chance of the disease, or in the case of CTX, probably more like 1 in 200,000. A positive result has a very high likelihood ratio, but let's say you're still only in a scenario where there's a 40% likelihood that that disease is truly present. You can then follow that up with either additional biochemical testing or genetic testing, and you're starting from the post-test probability of the prior test. So you're starting now at a 40% probability of disease. Now you do a test with the exact same information content, the same likelihood ratio, and your post-test probability, if that second test is positive, is now 99.7%. So you have arrived at the conclusion that this patient definitively has the disease of interest. So this is important because newborn screening is proceeding on multiple different roads right now. So one road is biochemical testing. And like I said, this is a very promising avenue. There are pilot studies going on right now of biochemical newborn screening for CTX. But another possibility is that whole genome sequencing and broad genetic testing will become a larger and larger part of the newborn screen enterprise. So there are multiple projects going on right now that are studying the implementation of whole genome sequencing as part of newborn screening. Just to highlight 3 of them, one's called BabySeq, that's based in Massachusetts. Beginnings is based in California, and the Guardian study is based in New York. So all of those studies using different, slightly different methodologies are studying the use of whole genome sequencing as newborn screening. So then your screening test and your diagnostic test have flipped in terms of which the role of genetics versus biochemistry. But the key is that we have both, and both are very good for CTX. So I think that CTX is very promising in terms of the potential to accurately diagnose patients despite starting at a very low pretest probability, whether you're starting with genetic testing or biochemical testing. So I want to give some examples now of how genetic testing has factored into newborn screen follow-up. So VLCAD, or very long chain acyl-CoA dehydrogenase deficiency, was added to newborn screening in most states around 2006, 2005. The reason that it was added, the justification for having VLCAD on newborn screening is to identify patients with who are at very high risk for cardiomyopathy and need implementation of a very low-fat diet starting in the newborn period. However, what we found was that most of the patients we diagnosed, first of all, the disease was way more common than we thought it was. And second of all, most of the patients that were diagnosed had a milder version of the disease than what we were used to seeing in our clinics. Mild VLCAD has very different characteristics. So as opposed to infantile onset cardiomyopathy that needs a very strict low-fat diet, adult onset patients don't seem to really respond to dietary interventions. They're at risk of intermittent rhabdomyolysis or muscle breakdown, and that usually has onset in adolescence or adulthood. So that's a very different version of the disease. It's the same enzyme deficiency, but it has very different clinical implications in terms of follow-up. So at the beginning, when we first started identifying this condition on newborn screen, we managed all of the conditions in the same way. Are you hearing me all right?
We can hear you, but we lost video, so we're trying to figure it out. You can keep talking for a second.
Okay. Good.
Okay, I think you're back on.
Okay.
Okay.
Thank you. So when we first started newborn screening for VLCAD, we didn't really know about this distinction, and all of the patients were managed pretty aggressively. And in retrospect, we know that we were really over-managing a lot of these patients, over-medicalizing them in a way that didn't really pass a risk-benefit calculus, knowing what we know in hindsight. So over the course of 10 years of newborn screening or so, it became clear that the most common mutation or pathogenic variant in the gene that causes VLCAD, and that mutation is called A283V, has significant residual enzyme activity and does not cause cardiomyopathy. So now, if you get a VLCAD newborn screen positive, we know that the babies that test positive, we can do genetic testing right away. We can get turnaround within a couple weeks. And we know that if they have that most common mutation, that A283V mutation, that they are not at risk of cardiomyopathy, and we can put them into a different management strategy. This is true to an even greater extent for a condition called Fabry disease. So Fabry disease is a lysosomal storage disorder. Probably most of the people in this room are familiar with it. This is not on the recommended universal newborn screening panel. However, a significant number of states have implemented newborn screening for Fabry. And what we've found in screening for Fabry is that, so this is from Oregon. This was a publication from 2022. In their initial couple years of newborn screening for Fabry, there were 50 positive results for males, 11 for females, and the majority of those all came from a single mutation called A143T. That A143T mutation has significant residual enzyme activity. It does not result in the classic symptoms of Fabry disease. There's a lot of work going on right now in terms of how that mutation behaves in terms of clinical manifestations. But it takes really subtle evaluations. So things like these cardiac T1 mapping, LGE, and feature tracking myocardial strain. So, and also very subtle assessments of peripheral nerve function. So it's clear that this mutation behaves in a multifactorial way as kind of a risk factor for some pretty late onset manifestations that aren't really consistent with classic Fabry disease. So that's another case where this genotype-phenotype correlation becomes really important in terms of follow-up once you've implemented newborn screening for a particular condition. A third example that I'll give you is Pompe disease. So this is a publication from a couple years ago. This is the first roughly 700,000 infants that were screened for Pompe disease in Illinois. Of those 700,000 patients, 3 of them had infantile Pompe disease, which is the intent of newborn screening, is to identify infantile Pompe disease and intervene with enzyme replacement therapy early in life to prevent permanent manifestations of both cardiac and skeletal muscle disease. Now, 3 out of 29 true positives on newborn screening had the official target of newborn screening, which is infantile Pompe disease. And Pompe disease is a disease that we've known about genotypes for quite a while. The folks at Duke have really carefully cataloged which genotypes are likely to result in infantile onset disease versus late onset Pompe disease. So for all of these that I've mentioned, this is really an ongoing project, but the genotype is really key information as we both confirm whether a newborn screen result is a true positive versus a false positive. And then once having confirmed that it's a true positive, kind of risk stratifying the patient to figure out the best next steps for follow-up. So for CTX, this is complicated. So the mechanisms by which the abnormal enzyme activity and abnormal metabolites result in clinical symptoms are complicated, and the outcomes are a little bit noisy for the reasons that I've mentioned. So the onset of these symptoms takes place over decades. And so there are cases where even identical twins or siblings with the exact same mutation have had different neurologic manifestations of disease or different age of onset of different symptoms. So it's clear that there's some aspect of these being multifactorial. However, we are starting to be able to distinguish some different categories of CTX disease. So the categorization that we really care about most is the question of, will a patient develop progressive neurologic disease or not? So cataracts and tendon xanthomas, diarrhea, those are all things that, those are all symptoms that you don't want to have. But the strongest justification for treating CTX is to prevent progression of neurologic disease. So distinguishing those patients that are at high risk for progressive neurologic disease versus lower risk of progressive neurologic disease is an important thing to do. So this is a publication from 2001. The lead author on this is Bianca Stelten, who's in the Netherlands. And they have a case series of 19 patients from 16 families that did not have neurologic symptoms of CTX. So these patients either had cataracts, tendon xanthomas, or diarrhea, but well into adulthood, so past the age that you would have expected at least one neurologic symptom by the classic description of CTX, these patients did not have neurologic symptoms. So the youngest patient here is 30, and this includes patients into their 50s. They also show us the genotypes for these patients. And I think we can start to, if we squint a little bit and start to kind of pay attention to genotypes here, we can start to maybe make some rough correlations. So let me talk through that a little bit. First of all, you'll see this arginine 395 mutation or pathogenic variant. So these missense variants, meaning that you're changing one amino acid to another, but otherwise leaving the protein intact. That missense variant is found in equal proportions among those with and without neurologic symptoms. So one way to think about that, that pathogenic variant one, it's the most common. Two, it seems to be compatible with CTX in the absence of neurologic disease, but there still are a lot of patients that are at risk for progressive neurologic disease. See, you're working on getting the visuals back?
No, we're just trying to keep everyone on time for flights to catch.
Sounds good. I will move along then. One of the keys from this case series of non-neurologic patients is that there are no individuals with biallelic, null, or complete loss of function mutation. So I think that might be a fruitful area going forward, is to think about what do patients look like that clearly have complete loss of enzyme activity. This is a second publication from Dr. DeBarber and her colleagues about another atypical case, patients without progressive neurologic symptoms, despite being at the age where you would expect that. These patients had, again, that arginine 395 missense change, but also an arginine 137 missense change. So that arginine 137 change has now showed up in multiple publications of atypical cases. We can look at population databases and look at what are the most common predicted pathogenic variants in the world. And we see some pathogenic variants that we know really well. But we also see, I'm going to draw your attention to the upper right corner here, this C2T2C. So that is what's called a start loss mutation. That's kind of a special category of mutations that often can have residual enzyme activity. And that turns out to be the most common predicted pathogenic variant in South Asia, or in folks of Indian descent. So I'm going to skip over that slide there in the interest of time. But this variant, C2T2C, is predicted to be one of the most common likely pathogenic variants in the world. However, it's only been published twice. 4 of the individuals with this mutation are in this case series of atypical cases, folks in their 40s and 50s that don't have any neurologic manifestations at all. So I think this is one to keep an eye on as a mutation that is both common, but also has the potential to have sort of an altered profile of the phenotypic manifestations of CTX. So CTX is a complex disease. We know that it's multifactorial in some ways, and it's variable. It's noisy in terms of what the clinical outcomes are. So clinical predictions based on genotype or specific metabolic profiles are unlikely to be discrete. It's going to be a spectrum, but we may get to the point where we can say in a probabilistic way that we expect someone to fall into a high penetrance or low penetrance bucket, or maybe an early onset versus late onset bucket. And those probabilities can inform clinical care, but they're going to require nuanced discussions of risks and benefits between doctors and patients, thinking about which patients merit pre-symptomatic treatment, where the risk-benefit calculus is in favor of starting treatment despite not having any symptoms, and maybe which patients are more appropriate for watchful waiting, looking out for the onset of symptoms, and then treating at a later time. So I want to say thank you to all of you for listening, and thank you to Hunter's Hope for supporting work in this area. Happy to take any questions that y'all have.